Hello, this is Dr. Edward Fox from Central Texas Neurology Consultants in Round Rock, Texas. Welcome to this educational activity on the management of multiple sclerosis. Joining me in this case-based discussion is my colleague Lori Mayer, who's also from Central Texas Neurology Consultants in Round Rock.
The following audio is from a two-part presentation with Drs. Edward J. Fox and Lori Mayer. This audio is part of a certified educational activity titled Personalizing Multiple Sclerosis Care in an Era of New Therapeutic Options and Updated Clinical Course Descriptions. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/QJH. A printable transcript, slides, practice aids, and other features are also available.
Let's begin by discussing our first patient. Marissa is a 28-year-old married Hispanic female who is currently employed as an art historian at a local university. She and her husband are thinking about starting a family. Notable family history is that her maternal grandmother had MS. Prior medical history is that she had back pain following a motor vehicle accident 3 years ago and still experiences intermittent mild pain, tenderness. Her current medications are loratadine, 10 milligrams a day for seasonal allergies, and she does have contraception in the form of an intrauterine device.
As for Marissa's recent medical history, she was recently evaluated by a primary care provider for worsening back pain. Starting in June 2015, she presented with current symptoms which included numbness from left lower waistline down through the leg, right leg weakness making her gait very unstable. She also reported experienced blurred vision in her left eye about 8 months before her current symptoms manifested. X-ray of the lumbar spine ordered by the primary care provider showed mild spondylosis. However, symptoms did not improve with chiropractic care, so the primary care provider ordered an MRI of the lumbar spine.
The MRI findings of the MRI of the lumbar spine was essentially unremarkable, although an intramedullary lesion was seen within the cord at the level of T11. An MRI of the brain and cervical spine was then ordered. The key findings of these studies were more than 20 supratentorial and infratentorial signal abnormalities, many of which were paraventricular with multiple lesions in the corpus callosum, some of which were gadolinium enhancing. Suspected signal was also seen at C2 and C3, and the spinal cord signal abnormalities were seen at T5, T6, and the one at T11 that had previously been seen. Marissa was then referred to a neurology clinic.
In her neurology examination, she presented with numbness, left leg, banding across lower torso. She also had complaints of fatigue and feelings of sadness, decreased visual acuity, 20/20 right eye, 20/40 left eye. Also an afferent pupillary defect, left eye, was noted. She did deny pain on movement or any color desaturation. Muscle strength, 5 out of 5 in major muscle groups. Reflexes, 2 out of 4 with the exception of ankles, 1 out of 4. Her tandem gait was slightly unsteady.
The 2010 Mcdonald criteria for the diagnosis of MS includes dissemination in space, which is one or more lesion in 2 or more of the 4 CNS locations, including paraventricular, juxtacortical, posterior fossa, and the spinal cord. Dissemination in time is the simultaneous presence of asymptomatic gadolinium-enhancing lesions and a separate non-enhancing lesion at any time, or a new T2 and/or gadolinium-enhancing lesion on follow-up MRI with reference to baseline scan, irrespective of the timing of the baseline scan. Lesions in symptomatic regions are excluded from the count, especially in the brainstem and spinal cord syndromes.
In describing the 2013 MS phenotype for relapsing MS, we have clinically isolated syndrome, which is not active or active. We also have a relapsing remitting disease, which is not active or active. The disease activity is determined by clinical relapse and/or MRI activity. Marissa's diagnosis was relapsing multiple sclerosis, which was active over the past 8 months. The assessment plan included labs that were ordered: CBC, CMP, vitamin D level, JCV antibody, varicella titer, and TB screen. The topics discussed with the patient included the rationale for treatment with disease-modifying therapies and the various disease-modifying therapies that were available.
The rationale for early treatment with disease-modifying therapy is that neuroinflammation and neurodegeneration occur early in the disease course. Individuals with a first clinical event accompanied by MRI findings consistent with MS who do not receive treatment have a high probability of experiencing further clinical disease activity. Early disease activity and disease course appear to impact long-term disability. Cognitive changes, depression, and fatigue occur very early in the disease process. So let's discuss the disease-modifying therapy profiles, starting with interferon betas. There are numerous different interferon betas, including intramuscular interferon beta 1A 30 micrograms once weekly, which has been shown to significantly decrease relapse rates, disability progression, and MRI outcomes compared to placebo. Interferon beta 1A 22 or 44 micrograms 3 times per week subcutaneously has been shown to significantly reduce relapse rates, disability progression, and MRI outcomes compared to placebo. Interferon beta 1B 250 micrograms every other day subcutaneously has been shown to significantly reduce relapse rates and MRI outcomes compared to placebo. And then pegylated interferon beta 1A 125 micrograms once every 2 weeks subcutaneously was shown to significantly reduce relapse rates and MRI and disability outcomes compared to placebo. The evidence trial showed that interferon beta 1A 3 times weekly subcutaneously was more effective than intramuscular interferon beta 1A 30 micrograms once a week.
So in discussion of safety and tolerability of interferon betas, common adverse events included injection site reactions, flu-like symptoms, depression, elevated liver function tests, decreased white blood cell counts, and hypothyroidism. As far as the patient monitoring, prior to treatment initiation, liver function tests, CBC, TSH were ordered. During treatment course, the LFTs, the CBC, and the TSH are monitored.
Let's move on to the disease-modifying therapy profile of glatiramer acetate. GA 20 milligrams per day subcutaneously was shown to significantly reduce relapse rates and MRI outcomes compared to placebo. Glatiramer acetate 40 milligrams 3 times weekly subcutaneous was shown to significantly reduce relapse rates and MRI outcomes compared to placebo. In the Beyond trial, similar efficacy was seen between GA 20 milligrams a day and 250 micrograms and 500 micrograms of beta interferon 1B. In the Regard trial, similar efficacy was seen between GA 20 milligrams a day and thrice weekly interferon beta 1A subcutaneously. Common adverse events associated with GA include injection site and post-injection reactions and lipoatrophy. As we now enter the era of biosimilar disease-modifying therapies, the GATE trial showed generic GA 20 milligrams per day had equivalent efficacy, safety, and tolerability compared to branded GA 20 milligrams per day. Generic 20 milligrams per day was recently approved for the treatment of relapsing MS. We next turn to teriflunomide. In the TEMSO trial, 7 milligrams per day of teriflunomide significantly reduced relapse rates and MRI outcomes compared to placebo, whereas 14 milligrams a day of teriflunomide significantly reduced relapse rates, MRI outcomes, and disability progression compared to placebo. In the TOWER trial, 14 milligrams per day of teriflunomide significantly reduced relapse rates and disability progression compared to placebo.
Discussing safety and tolerability of teriflunomide, common adverse events include elevated ALT, alopecia, diarrhea, hypertension, nausea, and paresthesia. Patient monitoring prior to treatment initiation includes negative pregnancy tests, TB screen, ALT bilirubin, CBC, and blood pressure. During the treatment course, ALT is monitored monthly for the first 6 months, as well as monitoring the blood pressure periodically. If pregnancy is suspected, teriflunomide is pregnancy category X and requires cholestyramine or activated charcoal for accelerated elimination. Marissa's lab results included a normal CBC and CMP, a positive VZV antibody titer, negative TB screen, negative JCV antibody status, normal vitamin D level, as well as the blood pressure 130/78.
So let's have some discussion points that we would talk about in this case. One is, what prognostic factors do you consider most important in this case of Marissa in making that treatment decision of what medicine you go for first?
Well, there are several things that you look at, and she does have several poor prognostic factors. The one thing that jumps out to me in this specific case are her MRIs and the number of lesions that she has on the brain MRI, as far as a lesion in the corpus callosum, which is enhancing. In addition, she has them in the cervical and the thoracic spine. And then I think about the relapses that she had, which from her medical history, it looks like she's had 2, and what type of residual disability she may have experienced with that. So those are probably the 2 top things.
I can certainly understand why it's very alarming to see MRIs that are as dramatic as that, multiple lesions throughout the spinal cord and in the brain. So I certainly agree with you on that. The next question we should handle is, how do we look at the JCV antibody status for this patient in helping to make a treatment decision?
Well, I think considering the prognostic factors that Marissa has, that natalizumab would definitely be an option, and her JCV antibody status was negative.
I do think that we use that in terms of giving us a better feel for our options. It is true that she would have qualified for almost all of the clinical trials that we discussed, in that she would be a patient who had disease activity and MRI findings consistent with MS, so we can look at the results from those clinical trials to try to guide us. It's very hard to determine whether one medication is better than the other in the absence of true head-to-head studies, and we have very few of those. But on the other hand, we do have information that we can look at in these clinical trials which help guide us towards deciding for her what may be the best treatment option as well.
Absolutely. So how do we discuss safety and monitoring with your patients?
I think that may be the biggest struggle that we have on a day-to-day basis with a patient who's coming to grips with a new diagnosis. Now they have to come to grips with the idea of how can we monitor them to see whether the medicine is effective, but also monitor for safety. So they do need to hear it, and I think that first, when they've accepted the fact that they have the diagnosis and accepted the fact that early treatment is the optimal strategy, then you can start talking about the medicines, and when you go over the medicines, it's generally best to try to categorize them somewhat, but to really be able to hone it down for them. Because now, with over a dozen branded medications, it's really very difficult, in fact impossible, at one appointment to go over that kind of information. So we need to distill it down, and we need to talk about the need for monitoring for safety, the need for monitoring for efficacy of the drug over time, and what they should expect in terms of tolerability, how they're going to feel on the medicine, to give them some outlook as to what to expect.
Do you assess their risk assessment too?
I think a very important question that we ask early on is if they know anybody with multiple sclerosis. Because if they do, they may have experience themselves in knowing something about the medicines. And they may have biases of thinking that a medicine was very effective or not effective. I think that's a huge shortcut for us in having this conversation.
Let's move on to our next case. Adam is a 36-year-old male of English descent. He's been married for 14 years with 2 children, aged 10 and 6. Currently, he's employed as a computer programmer for a technology startup company. He has no family history of MS or other autoimmune diseases, and he's also a marathon runner.
His prior medical history is that he had optic neuritis in the left eye with 2400 central vision at onset. The visual acuity improved to 20/30 following high-dose steroid treatment. A brain MRI showed multiple demyelinating lesions consistent with MS. He did have a history of unexplained numbness from the waist down the previous year, but no evaluation was performed. All lab results were within normal limits. Patient was informed about the diagnosis of multiple sclerosis and the need to start a disease-modifying therapy.
Adam's treatment history included in 2006, he started interferon beta-1A, 30 micrograms IM, 1 time a week. In 2008, he switched to interferon beta-1A 44 micrograms subcutaneously 3 times a week after experiencing breakthrough clinical and MRI disease activity. He had no clear relapses observed during treatment with this particular therapy. So, in 2013, he presented with a gait disorder, spasticity, and erectile dysfunction. Muscle strength, normal, 5 out of 5. Reflexes, 3 out of 4 in the upper and lower extremities, and toe tap slowed on the left side. Adam requested a change in medication due to worsening stamina and inability to run. Natalizumab, fingolimod, and dimethyl fumarate were all considered.
Let's discuss the disease-modifying therapy profile of natalizumab. In the AFFIRM trial, natalizumab significantly reduced relapses, MRI disease activity, and disability progression compared to placebo. The potential side effects, as per the product insert, included headache, fatigue, urinary tract infection, arthralgia, lower respiratory tract infections, gastroenteritis, vaginitis, depression, extremity pain, abdominal discomfort, diarrhea, and rash. The patient monitoring prior to treatment initiation and during the treatment course includes LFTs, CBC, and monitoring the JCV antibody status. We now have a PML risk stratification for natalizumab that includes 3 factors. One is the JCV antibody status, whether it's negative or positive, with the patients who are negative having the lower risk of development of PML. We also then have the risk factor as to how long the treatment has been going on, whether it's been less than 24 months, between 25 and 48 months, or above 48 months. We have different risk levels for those patients who are JCV antibody positive. We also have an increased risk for patients who have any prior history of immunosuppressant therapy.
Disease-modifying therapy profile for fingolimod includes the FREEDOMS trial, where 0.5 milligrams of fingolimod significantly reduced relapse rates, MRI outcomes, and disability progression compared to placebo. FREEDOMS 2, 0.5 milligrams fingolimod significantly reduced relapse rates and MRI outcomes compared to placebo. The third trial, TRANSFORMS, 0.5 milligram fingolimod significantly reduced relapse rates and MRI outcomes compared to intramuscular interferon beta-1A, 30 micrograms 1 time a week.
Potential adverse events associated with fingolimod include headache, diarrhea, macular edema, hypertension, LFT elevations, and cough. Prior to treatment initiation, a VZV titer, LFTs, and CBC should be obtained. Patients must also undergo first-dose cardiac monitoring, a baseline ophthalmologic exam, and spirometric evaluation when indicated. During treatment course, a follow-up ophthalmologic examination should be performed 3 to 4 months after treatment initiation. LFTs and blood pressure should also be monitored periodically.
Disease-modifying therapy profile for dimethyl fumarate includes the DEFINE trial, which was dimethyl fumarate 240 milligrams 2 times a day, and significantly reduced relapses, MRI disease activity, and disability progression compared to placebo. In the CONFIRM trial, dimethyl fumarate 240 milligrams 2 times a day significantly reduced relapses and MRI disease activity compared to placebo.
The potential adverse effects of dimethyl fumarate include flushing, abdominal pain, diarrhea, and nausea. Patient monitoring includes testing prior to treatment initiation of a CBC within the previous 6 months, and during the treatment course, a CBC after 6 months of treatment and every 6 months thereafter. The assessment for Adam included normal CBC and CMP, a positive VZV antibody titer, negative TB screen, a positive JCV antibody status, and a blood pressure that was normal at 119/85. The patient had no cardiac symptoms, but did have a right bundle branch block noted on an electrocardiogram.
Adam started dimethyl fumarate in September 2013. A follow-up brain MRI 6 months later showed a new 5 mm GAD-enhancing lesion, but no clinical relapse. In addition, a repeat MRI after another 6 months showed 2 additional T2 lesions and a T1 hypointense lesion not previously noted. Clinically, Adam noted a greater issue with dragging of the left leg.
A switch to fingolimod was then performed with Adam. He switched to fingolimod in 2014 due to the breakthrough disease activity despite the treatment with dimethyl fumarate. Adam developed increased PVCs and was evaluated by a cardiologist. He had a normal echocardiogram, but a repeat electrocardiogram showed the previous right bundle branch block. The cardiologist was unsure if the PVCs were due to fingolimod, so the decision was made to discontinue treatment with this agent. And at that point, treatment with alemtuzumab was discussed. Discussing the disease-modifying therapy profile of alemtuzumab, the CARE-MS-1 trial showed that alemtuzumab significantly reduced relapses compared to thrice-weekly interferon beta-1a in previously untreated patients with MS. In the CARE-MS-2 trial, alemtuzumab significantly reduced relapses and disability progression compared to thrice-weekly interferon beta-1a in patients with MS who relapsed despite first-line treatment.
Prior to initiation with alemtuzumab, a TB screen, VZV titer, skin examination, CBC with differential, serum creatinine, urinalysis with urine cell count, and a thyroid function test should be obtained. High-dose corticosteroids should be administered immediately prior to infusion with alemtuzumab for the first 3 days of the treatment course. In addition, antiviral prophylaxis for herpetic infections should begin on the first day of each treatment course and continue for at least 2 months following treatment or until the CD4 lymphocyte counts are at least 200 cells, whichever occurs later. Patients must be monitored for 2 hours after each infusion. And alemtuzumab must be administered in a setting with the appropriate personnel and equipment to manage anaphylaxis and/or serious infusion reactions. Ongoing monitoring includes the CBC with differential, serum creatinine, and urinalysis during treatment and for 48 months after the last treatment course. Thyroid function testing should be obtained once every 3 months during treatment and for 48 months after the last treatment course. And an annual skin examination should be performed.
So, what is the potential role of emerging therapies in the management of patients with MS such as Adam? Ocrelizumab is a humanized anti-CD20 monoclonal antibody. The OPERA-1 and OPERA-2 trials showed this agent was superior to thrice-weekly interferon beta-1a in terms of relapse rates, MRI outcomes, and disability progression. The most common AE associated with ocrelizumab was infusion-related reactions. The ORATORIO trial, which was conducted in patients with primary progressive MS, demonstrated this agent was superior to placebo with respect to disability progression, time 25-foot walk, and changes in whole brain volume. Diclizumab HYP is a humanized anti-CD25 monoclonal antibody. The DECIDE trial showed the efficacy of this agent was superior to that of intramuscular interferon beta-1a with regard to relapse rates and MRI outcomes. The rate of infection, rash, and LFT abnormalities were higher with diclizumab HYP than with interferon beta-1a.
In the additional assessment of Adam's case, a CBC with differential was normal, a CMP was normal, serum creatinine level was normal, urinalysis with urine cells was also normal, thyroid function normal, and blood pressure within normal limits, 125/84. The skin examination was additionally normal. In discussing Adam's case, how important is the medical history in determining which products are appropriate either as first or second line treatments?
First line treatments are often easier for this in that we have many choices now for quite a few of the patients. It's the second line treatments that become more problematic because we have to look at why a patient is getting off of a first line treatment. Is it because of a tolerability problem? That's an entirely different scenario than if they have breakthrough disease, such as Adam's case. He started with interferon beta-1A intramuscularly, had breakthrough activity, and went to a more frequent dosing of beta interferon. He also, at one time, was on dimethyl fumarate and had breakthrough activity and went to fingolimod as well. So we see that patients can have breakthrough activity on medicines, and then we have to think it through as to whether we need a change in dosage, a change in mechanism of action, a completely different approach to that type of patient. Another discussion point we have about Adam's case is what factors would determine whether a washout period was needed prior to starting a new disease-modifying treatment.
There isn't any consensus on what the washout periods are for the disease-modifying therapies. However, we look at the clinical trials, the evidence of the clinical trials. We also look at the long-term safety monitoring, I think, in making our decisions as well as our own personal experience.
I do agree that we have certain criteria that we use, especially with laboratory values, to try to help guide us in determining whether it's safe to start a new medication. We also realize the effects of prolonged washout periods, that you really do take on an additional risk of worsening of MS during that time.
How do we define success in the change of treatment?
I think we change the outcome by changing medications in the same way that we change the outcome with the first medicine that we would use. What we in fact are coming to expect is that a patient will have adequate control of the disease. And we measure that in whether they're having relapses, whether they're having progression of old symptoms or development of new symptoms that unfortunately come and stay rather than come and go. And we also look at MRI as an outcome measure now to determine whether we're stabilizing the MRI factors that we look for. And so I think that the relapses, the progression, and the MRI are the way that we judge any treatment change, just like we would from the very beginning.
So do you typically order an MRI prior to starting another disease-modifying therapy?
I do think we need a new baseline for that. I think that is very important. If we have a way to compare before and after for any drug, we're much better off. So even if I have a patient who has breakthrough disease activity, what we want to know is at the time of starting this medicine, and maybe shortly after starting the new medicine, a new baseline. And I think the other important factor for MRIs is that we have to make sure that we're really looking at active MS. In the days now of concern about progressive multifocal leukoencephalopathy, we have an obligation to look at MRIs and rule out other causes of neurologic worsening other than multiple sclerosis. Because if we assume it's MS and start a new medication, we may be going in the wrong direction for that patient. So this raises the additional question about how do we discuss the safety and monitoring with our patients?
Well, when we initially discuss the medication, I think we review with them the safety and monitoring procedures for each of the medications, and we're balancing the risk profile with efficacy profile. But on the other hand, the patient also needs to know exactly what their responsibility is in the whole monitoring process.
And I think that you've been able to generate handouts for patients that give them specific instructions. And I always encourage that because this allows them to be able to refer back to something. And I know that for some products, they have a risk management plan where there are backup systems to this. So they will be notified automatically if they're not going through with their standard treatment and standard monitoring afterwards with blood work or other testing.
So how do we balance our personal experience with the disease-modifying therapies versus the global experience that we see in the clinical trials?
I think one of the difficulties with looking at clinical trials is that it often can be a narrow slice of population that was allowed to be in the trial. Whereas in our personal experience, we have patients that wouldn't have necessarily fit into that criteria, but are excellent candidates for the medication nonetheless. Because we've learned through the clinical trials what patients may have contraindications to the medicine and which ones may have thought to be an issue but turned out not to be as much of an issue. What we really do need to do is look at the global experience where we've had patients who have been on the medicine for a period of time and allow us to communicate with our patients about what we have learned with our own experiences and the global experience, to keep updating them about what our expectations should be and what we feel about the monitoring necessities and how we need to make certain that they're having the most adequate safety monitoring they can have.
I think it's important that we do share with the patients and as well as other providers.
As for our conclusions today, the updated clinical course descriptions of MS have helped better define active disease, worsening disease, and confirm progression. Several novel agents and new formulations of established disease-modifying therapies have been approved since 2010. Several additional therapies are in various stages of clinical development. However, for some of these therapies, there is no consensus as to when they should be utilized during the course of MS as a first, second, or third-line treatment. As such, treatment decisions need to be individualized for each patient and involves careful consideration of the risks and benefits for each therapy and several additional factors.
That ends our discussion for today, and I hope you found it informative and useful for your practice. Don't forget to access the post-test and evaluation form by clicking the red Get Certificate button. And thank you very much for participating in this educational program on multiple sclerosis management.
This CME-CNE activity is jointly provided by the Consortium of Multiple Sclerosis Centers, Nurse Practitioner Alternatives, and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME-CNE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/QJH. This program is supported in part by independent medical educational grants from Genentech and Mylan Incorporated.